on, Mo. Good boy. Come on.
Welcome to Moments of Experience, a podcast inspired by my faithful best friend, Mo, a 14-year-old beagle who gave us moments of hope, compassion, and love during a time of tragic loss and life-threatening family illness. I'm your host, Geoffrey Smith, and I invite you to join me for powerful, uplifting, and sometimes even challenging conversations with some of the world's leading innovators in employee, patient, caregiver, and human experience. Together, we dive into the meaningful moments that shape us, move us, and inspire us to pursue our purpose in life. I'm glad you chose to join us as we explore the big and small moments that bring meaning to our lives and connect us to our true calling.
So welcome to a brand new episode of Moments of Experience. I am so excited to talk to my guests today. And as listeners of the show know, I introduce my guest in my own words. I don't like canned bios. I think they're boring. So my guest today, Kelly Hines-Stellisch, she's a lot of things. She's a family and emergency room nurse practitioner, a dog mom, and a wellness coach that through her own struggles with burnout, discovered the cheat code to helping the healthcare workforce go from depleted to energized and from survival mode to loving work and life. That's how I see you. Feel free to introduce yourself in your own words.
Thank you so much. It's so funny to hear that description because it's like, oh, I guess that's all technically true. Yeah, my name is Kelly Hines-Stellisch. I am a family nurse practitioner and emergency nurse practitioner. I live in Southern California, and I've been a nurse since 2015 and a nurse practitioner since 2018. So, gosh, we're coming up on 11 years as a nurse and 8 years as an NP, and it's been a journey. And I think had you asked me at the beginning if I would have a wellness coaching practice, I probably would have laughed at you. It's like, there's no way. But, you know, life just kind of does what it does. And so here we are. Yeah. I'm so fortunate to be able to do this work. It's so cool.
Yeah, absolutely. And how I start the show is I share something with my guests, something that I've learned from you or something that truly resonates with me about your work, because that's the reason I invite people on. And when I ask my guests about the moments, that shape them, move them, and inspire them to pursue purposeful outcomes in healthcare and just in life, it's amazing that almost exclusively the moments they share are a reconnection to purpose. After completely being disconnected from their why, after burnout and the broken healthcare system basically rips it out of them. And you mentioned your coaching business. That's what you do. You are reviving wellness. You are getting it back. You're because connection to purpose allows people to authentically show up in healthcare and in life. So that's what resonates with me so much about your work. And I love evidence-based practices. I love research. I'm kind of a research nerd when it comes to workforce well-being. And I read a study you co-authored and published in the Journal of Emergency Nursing through the Ohio State University. And some of the stats they used were really interesting. I've seen them before. It's they weren't exclusive to what you were doing in your study, but the fact that the importance of real investments in meaningful wellness and well-being practices in the world of healthcare. I mean, the proven ROI, we've seen it over and over, a 1% positive impact in retention leads to a bottom line of well over $250,000 to these healthcare systems. And all the research proves this out. But I always like to say healthcare is at the forefront of clinical innovation, yet lags 30 years behind the private sector in people strategy. So I'm going to ask you from your unique perspective, I'm going to ask you a really difficult question. and get your thoughts on it. So, because I work with numerous health tech startups, nurses and doctors and healthcare innovators that have, in many cases, left the bedside to innovate for the bedside. And so here's my very difficult question for you. Why is it that no CFO that I have come across in healthcare will ever acknowledge a hard dollar ROI gained from getting our arms around and investing in the well-being of the most critical workforce on the planet?
I have an answer. It's not. I was like, oh my gosh, can I answer this question? I think I have an answer. I think it's twofold. Especially as a frontline clinician, I know that there are things that I don't know about leadership, right? I know where my knowledge and skills and expertise are, and that is delivering high-quality evidence-based care at the bedside. I did complete my Doctor of Nursing practice through The Ohio State University, and I think part of the beauty and, admittedly the frustration of that program had nothing to do with the program design and everything about the fact that everything I learned during the course of my doctoral degree was all about admin, really, and leadership. Even though I picked the clinical expert track at Ohio State University, I still found that the majority of things that I was learning about had to do with leadership, because as DNPs, our role is to translate the evidence. Jeff, this is a statistic that won't be lost on you, and it probably won't surprise you either, that we know that it takes about 17 years from when something is found in bench science research to be translated to the bedside. 17 years. And so part of the innovation and the impetus behind the development of the Doctor of Nursing practice degree was to close that gap. So my role is not necessarily to generate new research. It's about taking the pool of existing knowledge that we have and shortening that timeline to implementation. So most of my coursework was about learning about stakeholder engagement, learning how to calculate ROI, learning evidence-based policy or evidence-based practice and how that is different from evidence-informed policy decisions. Evidence-informed it's an interesting distinction, because to me, as a person of science, I think, okay, if this is what the science says, then I'm not sure why we have any more questions. We should just be doing what the science says wholesale. And so to switch to evidence-informed, it's more about, well, you have to understand what the key stakeholders' interests are. And really, you're trying to thread this careful needle of satisfying everyone while also creating an evidence-informed approach. And I'm like, if the evidence isn't leading us, then I don't think I can do C-suite leadership, because I think I would probably be perceived as too focused on doing what the science says and ruthlessly zeroing in on that. So, long-winded way of saying, Jeff, I think part of why sometimes hospital administrators have a difficult time making those difficult decisions and implementing system-wide changes to help keep their workforce safe, I think there are probably 3 reasons for that. 1, there aren't enough people like me who can speak both languages. I tell my husband, I said, I think my DNP was more about learning how to speak admin and the language of admin, learning how they work, learning how they think, learning what their motivations are, than actually practicing medicine at the bedside. So I don't think there are enough of us frontline clinicians that speak both languages. We lead with heart. We lead with patients first. We lead with these compelling, gripping, heart-wrenching stories. And that's not the currency of admin. That's not a language that they understand. And so that's the first thing. I think that there's a translation piece. I think we're literally speaking different languages. I think the second thing is that, likewise, how it takes 17 years from what we know from bench research to land at the bedside, I think ideas and pieces of knowledge that we know in the literature take time, although I don't know what the timeline is, to permeate the consciousness, the collective consciousness of people. And so part of what's challenging is that I think that sometimes CEOs believe that burnout is still a personal failure. Now we have ample research that says that's not true at all. And I think if you work in this space, if you live, eat, sleep, and breathe burnout the way that I do, the way that you do, the way that my fellow wellness folks do, it's the standard upon which we operate, that we know that it's not a personal failing. I think that we in this space have accepted that, and I think our colleagues in leadership space are behind. I think it's still viewed as a personal failing, which then leads to item 3, which is in a world where you have competing demands, financial demands, right? Where you're looking at making sure institutions keep running. And then now when you look at some of the policy changes coming with the Big Beautiful Bill and all that, we're looking at significant cuts to hospital reimbursement for Medicare and Medicaid. So in a climate where it feels like the walls are kind of closing in and they're being asked to do more with less, then how could they prioritize something that's a personal failing that people need to take care of on their own when they have X, Y, or Z other things on their list of things that they need to tackle? Right? There may be IT projects that need to be done. One of the hospitals I work in, we are falling behind and there's a budget shortfall. And so there are questions about if our hospital will have the funding, or if the system will have funding to help support the renovations needed for the hospital so that it can come into compliance with seismic requirements for the state of California, right? So there's that, right? There are all of these other things. We have a pretty strong nursing union here in the state of California. And so there are just those other forces. And so I don't think it's because administrators and leaders don't care about the workforce. I think it's the tyranny of the urgent. They have a mile list, a mile long to-do list, just like we all do, right? And so I don't know that it lands in their top 10 because we don't have enough people that speak a language that resonates for them. And there's a lag time with them accepting what we've known in the literature to be true for years, which is that, 2/3 of burnout comes from systemic level things like staffing policies, PTO, sick time, vacation inbox coverages, parental leave, 401k, things like that. And so that's my answer, which is frustrating in this space. And also I have a lot of empathy for our hospital leadership because they have a big job. And I think they know that it's important. And so they want to do something. And so then sometimes I think what happens is that it feels performative. You have wellness rooms that somebody donated a lot of money to the hospital and they put their name on a plaque and it's the so-and-so wellness recovery room. And it's like that room sits empty most of the time because, candidly, I worked a 13-hour day on Tuesday in the emergency department. I did not take a break for lunch. I ate lunch at my desk because there is no one to take care of my 10 patients while I eat, right? So those rooms are beautiful, and I don't think I've ever seen the inside of one of them. I think they're beautiful. I've seen pictures of them, but I think it's one of those things. They want to feel like they're doing something, so then they have something to point to. Say, look, this is what we've done. We do care. And it's not that it's not meaningful. It's that there's not enough context or understanding about what the lived experience is of frontline staff to know what would be the most effective interventions are. And if the people with whom you're speaking are still operating under this paradigm of, well, it's a personal thing anyway, well, then, of course, we have an individual-based solution, right? Instead of the system-wide changes that we know would actually move the needle.
So much insight there. And so much of that I live daily. Because in many cases, I am the bridge for my health tech founders, I am the bridge to be that translator, to be that person that, how do we take an investment in our people? How do we build a business case? How do we talk the language of the administration? So much like you, I've learned to be fluent in 2 languages in healthcare. I know the clinical side, like you said, that lives in that burnout, that lives in that life and death situation every day. We know you get it, but there is a disconnect between the clinical side and the administrative side. And the one thing I always say is it's not always sinister. I don't want my healthcare executives out there listening to think, and as you stated, but I have had situations. I'll tell you a quick story. So I was bringing in a modernized employee engagement program, which is really my business in healthcare, to a 25,000 plus employee health system in my backyard here in Connecticut, one of the best academic health systems in the world. And I know that because they cared for my wife during her battle with cancer, and it was amazing. The clinical side, absolutely amazing. But I was having trouble with the administrative side, getting this big project across the finish lines for a lot of the reasons you mentioned, right? Budgetary concerns, openness to change, openness to trying something that wasn't the way we've always done it, right? That is one of the biggest challenges in healthcare, is just doing it, trying some innovative in an industry that is innovation averse. And we got to this final meeting, and I sat down. I had people from my company fly in from all over the country. We had the CHRO there. We have the CEO there. We have the CFO there. We have the admin to the CEO. And I just looked around the room and I just said, where are the nurses? And the answer I got was stunning. And it was that they weren't invited. And I stopped the meeting immediately. And I just said, this meeting is over. And I had some people with my company that weren't too thrilled with me, that had flown in from all over the country to finish this project. And as I walked out of the boardroom and had the CHRO chasing me, said, you have no idea how hard it was to get all these people together for this. And I just said, if you don't involve the people with the problem in the problem solving, it will lead to mistrust, which is, and as I said, in this case, it wasn't necessarily sinister. They were saying, well, they're so busy. We didn't want our CNO to take an hour out of her day. We didn't want a frontline nurse and a nurse leader to be pulled out of the field. So they weren't saying we don't want them there. They were assuming they wouldn't want to be there or don't have time to be there. And I said, because the system is so near and dear to my heart, we could not take your money when I know a project will fail. Because when we roll this out to the nurses, they are going to view it as the administrative flavor of the month, even though you're investing in something that is tremendous and is truly going to get your arms around this critical workforce, but they won't see it that way because you haven't involved their voice in the problem solve.
That's right. That's exactly right.
So what I do for a lot of my health tech founders is, how do we repair the bridges of mistrust between the clinical side and the administrative side? And I had one, my very first guest on this program, and there's a reason she was my first guest. She's one of the most amazing, compassionate people in the world. She's the world's leading educator in putting compassion into practice in healthcare. And she looked at me one day, and she's the sweetest, loveliest person in the world. And she just said, I saw anger in her eyes for the first time. And she said, Jeff, why do I have to build a business case for compassion? And I said, don't worry. And she's an RN as well. And I said, don't worry, I'll help you with that. But yeah, it's one of those things that it's frustrating for me when I talk to my founders and they say, Jeff, if we do this stress program or we do this burnout program or we do this engagement program, we've seen in our studies that we lower turnover by 3% and all of these things. And I said, get that out of your head because they're not going to give you credit for it, no matter what. So the idea is how do we, as you said, be bilingual to show the impact in the manner that they like. And the one good thing, and this is something that I hope gives you hope and everything like that. The one thing I've always seen. So there was this one floor during my wife's journey where everything was different. The food service employee sang to her when she brought her lunch. The environmental service person always called me by first name. The nurse leader was an amazing, compassionate soul. And I went back to that health system because I worked with them. And I said, hey, can you do me a favor and can you pull HCAPs on this one floor? Because that's one language that everyone in the healthcare system cares about, even finance. And they said, well, we don't pull it that way. That's a top-down thing. We pull that organizationally, not by floor. And I said, do me this favor. And it took him like 60 days, but 60 days later, he called me on my cell phone. He says, Jeff, through the roof. I've never seen anything like it. How did you know? And I said, because I felt it. And I told the story about the food service employee that sang to my wife, to the CEO and the CHRO. And they said, Jeff, I had no idea things like that happened inside of our walls. Like you said, the disconnect between where the work and the magic is happening. But the good thing that I've learned through this and the justification and the translation is that any healthcare system, there are pockets of brilliance somewhere. I go up one floor, down one floor from that floor, and it felt completely different. But when we can find where it's being done right, where the group, where the teams, and not the teams that tree up to a traditional org chart, the teams where the actual work happens, say, my teammates have my back. And when we find those teams, then we can actually scale through an organization and prove, because here's the good news. Investment in our people, in your business and wellness, in my business or engagement, in other people, other clients I have that are in stress reduction or burnout prevention or whatever the case may be. I have never seen a time where an investment in the well-being of the healthcare workforce did not translate to HCAPs, did not translate to patient experience. It has not happened once. And we talk about me and you being bilingual. My job primarily has been to connect those dots to those patient experience scores, those employee experience scores that HR cares about, so that they can bring a wellness program in. Because when I talked to 25 of the top chief wellness officers in the country in a project I was doing, and almost to a person, they stated that their budget for wellness was their salary. That we have to prove out these investments in our people. We have to prove out the investments in what coaching does, what you did that study with the Ohio State University and all of those things. And it's frustrating, but you said, I say they're 30 years behind. You said it takes 17 years. Well, I could tell you right now, healthcare is at a crossroads and is going to, we have our largest generation leaving the workforce at the exact same time they're going to need more care. And we have a burned out and different generation of the workforce that need to step up. As I said, we don't have a nursing shortage. We have a retention problem.
100%.
The younger generation has options. The younger generation can say, hey, if I don't feel seen, heard, valued, I'll do something else.
Mm-hmm. Yeah, that's so true. I I have worked with so many talented physicians, NPs, PAs, and nurses in my career. And it breaks my heart now at year 10 or 11, year 8 as an NP, that so many of them have left. I work as a nurse practitioner in the same emergency department where I was a nurse before. So that's an interesting and unique experience, right? And so I worked in this emergency department as an RN from 2016 to 2018. I was in school the whole time to become a nurse practitioner. I was a nurse practitioner for 5 years before I came back working in the emergency department, this time as an NP. And I was so excited to go back and work with my colleagues because I was like, oh, like the gang's all back together. And I walked back in and I didn't work. I recognized one person out of 20 nurses, 30 nurses. All the docs and NPs were the same. I didn't see any of my nurse friends at all. And again, there's 2 or 3 that stayed, but the rest of them, they got burned out and they left. COVID did something. And I'll tell you though, I think when I was doing the research for my project, burnout has actually been documented in the literature as early as 2013. Doctors Sinsky and West, they were doing a lot of work on physician wellness around 2017. So all of this predates COVID. And my experiences with burnout were once as a nurse, 2017, and again as an NP in 2019, both times predating the pandemic. And then COVID hit, and it's like, I don't know. I feel like a switch got flipped, but it unlocked the floodgates. We had intense pressure on a whole cohort that were already burned out to begin with. And just like we always do, we rally. Like, it makes me emotional thinking about it because, in the early days of the pandemic, I was working at an urgent care. So I was frontline, but not in the ER. We were doing COVID testing, and it was a scary time for all of us, right? Because here I am, being confronted by this virus, every day, actually, with an N95 and gown and gloves. And I'm like, okay, I've seen 40 patients today, and any one of them could get me sick or get my husband sick, right? Just a scary time, but at least I had equipment. My colleagues in the ER, they were cutting open holes in trash cans to serve as gowns, reusing their N95 masks. Just the amount of trauma. And I love them, and they're wonderful, and they rallied because we love our community, we love our patients, and it hurt them so badly. It was a crucible effect, right? So much compression, so much pressure for the first, 2020 through probably late 2021, 2022, mid 2022. And then the wheels fell off. And that was an interesting thing I found in my research internally when I did my wellness coaching program inside of the hospital. Their internal metrics for turnover bore out that same pattern. The typical turnover rate in any department for nurses, APPs and physicians, they don't track quite as closely, which is an interesting distinction. But, for nurses at least, we had those data. And the typical turnover rates in any given 12-month period is somewhere between 10 to 13% on average. So 2020, it dropped 3.2%. 2021, it was still flat, maybe 4%. 2022, back to 9. 2023, it widened 30% turnover. It was this widening effect. It's like, okay, people can only take so much pressure for so long. And so it's like, I knew I had to do something. And, kind of happening in parallel, there was this stream of where I realized, both for myself and for my patients, information is not enough. I think sometimes what we can do, especially if you're a person of science, if you like to learn, if you have lots of different interests, it's really easy to get into the trap of reading a lot of things, absorbing a lot of things, listening to podcasts, reading books, reading these articles, talking about things, and lacking implementation. We're very heavy on the absorption, and we're very light on the execution. And I saw this in myself with my protracted recovery from burnout. It was probably 2 years before I fully got back to myself. And then with patients too, because quite frankly, if I could just tell patients what to do and they did it, I would be out of a job. We all would, right? And so like there's this kind of obvious thing that of course we all know that it requires more than just information. Knowing has never actually been enough. You have to know and do. And so it was the confluence of those things. It was like, okay, I was learning about coaching, and then the pandemic happened, trying to recover from my own burnout. And I realized I know all of these things, but I'm not doing them. So then how do you close that gap so that I can get better? And then how do I help my patients close that gap so that they get better? This is coaching, right? And so then that's when I pivoted. That's what I did my DNP project on. And so that was the start of, my wellness coaching program, Reviving Wellness. And, admittedly, I know that it's, it's an individual solution, but I think it dovetails very nicely with your first question, which is, why do hospital leadership have a difficult time even accepting the ROI that's so clear on investment in their people, and they still don't? I think part of it too is that it's just like turning a battleship. There are just the time horizon for change, also something I learned in my program, was so much longer than what I was expecting. So there's a piece of expectation management, right? So I didn't know, and I don't think many of my, frontline colleagues know that, if you're talking about a real implementation of an actual change, timelines are usually 18 months to 2 years, I think on the short end, in a large health system, right? That was a new learning for me. And I think most of my colleagues probably don't know that. So then there has to be this level of like patience and tolerance for that, because you're still suffering while these people in their offices are trying to figure it out. It's like, but my lived experience every day is I'm still stuck in the mud, and we're perseverating over, turf battles. And so, but I just say that to say, I think in an environment where hospital leadership also probably feels that the walls are closing in, they have to-do lists a mile long, they're asked to do more with fewer things. It's kind of human to want a quick win, right? It's human. And so I think that's probably part of why some of the wellness initiatives kind of flame out. There will be wellness carts that they come around and they have snacks, or massage chairs for you to get a massage. And it's like, but maybe we could just focus on making sure I get a break first. And then we could add on the massage. But making sure I get a break as an NP in the ER, because that's an important distinction. As nurses are protected by the nursing union, and there are union rules that dictate that they have a certain number of breaks in a certain time frame. As a nurse practitioner, I'm not subject to those rules. And so making sure that I get a 30-minute break in a 12-hour day is a much bigger task. You have to credential someone else. You have to make sure that they have the requisite skills and training. Are they a good fit? Are they bilingual? All of those things. And then how do you cover lunches in an emergency department? What does that look like? Those are much thornier questions than, do we have the budget to have a snack cart that goes around, right? And so you want to, right? I mean, and again, it's human to want a quick win. It is. I just think if we've got a 2 to 3 year timeline before something actually real materializes, but our seismic regulations are due before then those get prioritized. So I know it's not malicious. It never is. It's just the tyranny of the urgent, right? And so what happens is that, investing in your human capital just gets pushed down and down and down.
And the silent objection I always share with a lot of my clients is, I'll go back to some research. So PricewaterhouseCoopers did a study almost now 12 years ago, but it still holds true to this day, if not has gotten worse, that they say healthcare from an administrative perspective has half the budget and internal infrastructure, than a widget manufacturer down the street. Yet they are responsible for administering the most critical workforce on the planet. So a lot of times, as you said, for these 1 year, 2 year, 3 year projects that truly will create impact, a lot of those projects die not because of a lack of understanding about the need for them, but they die based on a fear of being able to stand the project up, a fear of being able to take that action that you said. Because you said it perfect. Healthcare people and administration, they have more data and research and stuff, but it's taking action where they slip on the banana peel.
Yes. Yeah, the implementation falls short. It does. And I tell my clients this too. So because part of the resistance that I have working with clients, not my resistance, but what I hear from them is, well, Kelly, this isn't going to fix everything. Me taking better care of myself isn't going to suddenly make, 4 more nurses appear. It's not going to increase Medicare reimbursement rates. So what are we doing? And then it's like, are you victim blaming? Are you reinforcing this pattern that says that it's my fault? And I'm like, no. That's not it. I want to I tell my clients this. It's 2 things being true at the same time. Number 1, we don't have to choose. We can rage against the machine, right? Like rally against the system, advocate for causes, and take care of ourselves at the same time. So we can do 2 things at once. And on top of that, I think the other truth, if I really have the relationship with them, I can say, hey, look, but also we're kind of the worst patients, right? Like we take terrible care of ourselves. And then they'll be like, well, Kelly, that's true. I'm like, right. So, it's hard to advocate for the system-wide change that you need to be able to rally on your day off to go to these meetings, right? If you're coming from a place of energy depletion. And so my program comes in and helps you create systems in your life so that you can exit survival mode, because decision fatigue is real. When you make decisions for 12, 13, 14 hours a day, where people really do, like the consequences are serious. I work in an ER. People can die, right? I'm not deciding anything else today. I don't know what we're having for dinner. Somebody else needs to decide that. I can't. And so, having a way to decompress, having a way to get your energy back so that you can go and advocate for the changes that you want, to be the one frontline clinician in a room of administrators, advocating for your colleagues, advocating for your patients. We should do both.
You can't show up for others without showing up for yourself first. And that's what our caregivers are tasked with, is taking care of themselves so they can take care of their patients. And anyway, we could go on for hours.
I know.
Sure.
We could, couldn't we?
The name of the show is Moments of Experience. And I asked each of my guests the moment or moments, it could be a couple, that shaped you, that moved you and inspired you to do the purposeful work you do every day.
Yeah, I think there are 4. So I'll summarize them. The 3 things that kind of came together that led to the route that I'm on now, and then one that kind of validates it. So I think the first one was just really synthesizing my own burnout experience. I felt lost. I felt like I was broken. I felt like, oh my gosh, did I waste years and hundreds of thousands of dollars on a path that I just wasn't meant for? So having that moment where I was like, something has to change. And then the second one was, working with patients when I realized that knowledge is not enough. Information is not enough. It never has been to actually create meaningful change. You have to have knowledge paired with action, right? So I remember a patient who I had when I was doing primary care, because I did full-time primary care for the first 2 years in practice. So I had a panel of patients, and we're supposed to counsel patients who are smokers every time they come in. Do you want to stop smoking? Do you want to stop smoking? And I learned pretty quickly, because I was younger than my patient, lecturing an older man does not work very well as a young woman, right? For more reasons than one. because it's not helpful. And so I said to him, I said, unless you've been living under a rock for the last 60 years of your life, I don't think there's anything I can tell you about how harmful smoking is that you don't already know. And so I'm not going to bring this up anymore. I'm just going to ask you, is this something that you're ready to change? And if not, we're just going to keep it moving. And it was probably 13, 15 months of seeing him like that when he finally told me. He's like, you're the one person that never pressured me to quit. He's like, I think I'm ready now. So I was like, oh, so it's not about knowledge, because he knew. It's about something else, something more human, right? Something, yeah, people do things when they're ready. So realizing, crystallizing that knowledge is just not enough until folks are ready. And then, yeah, the impact of the pandemic, not just on myself working frontline, because I worked urgent care for the first part of it, and then I was back in the ER as the pandemic was kind of on its last phases. But I have so many colleagues. It's just the amount of trauma inside first responders is not talked about enough, and it's just first responders and medical staff that worked frontline during the pandemic. So many feel forgotten. There's a heartache and a betrayal there that I think younger generations of providers are seeing, and they're like, also, that's not for me. Because it doesn't seem like there's a system-wide groundswell to protect them and to help them heal from what that was. So then, once I found coaching, I did my project, I realized this works, and I created a small business. The wins there are so satisfying. I have a client who, just so many stories from clients, but clients have been able to stop their anxiety medication because of the tools we teach. People in tears realizing, oh my God, I'm not broken. People have hope. I have an NP colleague, or she's one of my clients, but she's also a colleague. And, she said, I used to dread so much that I had another 20 years in this career. She's like, I'd wake up every day and just dread that I couldn't do another 20 years. Like, I cannot do this. And she said, for the first time in 3 years, she has hope. She's like, no, I know I could actually do another 20 years of this. I just need to dial in a few tools. I just need to keep practicing the tools that we went through or that we've gone over. And I know I can make it. And she's like, I have slivers of joy now where I remember why I do this in the first place. And it's like, oh my gosh, like it's amazing. So even out of so much heartache and pain, to see joy on the other side is such validation that it's like, no, this is the work that's meaningful. This is the work that creates an impact. These moments when I'm coaching clients where they're like, this is changing my life. It's amazing. It's so cool. It's so cool. Yeah.
And being present enough to find those small joys is something that I talk about, because if you just sit back, and my first job as a leader, all I did was celebrate big wins. And then I realized that's not going to work. Because and I say this in the outro of my show, so people are going to hear it again. But keep your eyes open and stay authentically present, because you never know when the small moments in your life can be truly life-changing and truly impactful. Those small moments of joy that bring us back to that place where, yes, I can do this for 20 more years, like you said, and you're coaching to help them see that hope and find those small moments of joy. So I really appreciate what you do.
Thank you. Thank you so much. This is such an amazing conversation. We could go on forever. I feel like.
Absolutely. Yeah. And I typically will watch the watch, because I like to keep things under a certain amount so people can consume it. But anyway, anything you'd like to add before we sign off? This was a great conversation.
No, it's wonderful. I think we can do both. We can take care of ourselves as clinicians while advocating for the system to change, and for our our administrators and our leaders listening, just know that people are really hurting, and take the longer view, right? We don't need to optimize short-term gains necessarily. If we can take a long view, 5-10 year horizons, it will pay. I mean, the ROI is just incredible, and the goodwill. I thank you so much. Really, this was so awesome.
Yeah, one thing I want to get across to people that I talk about a lot, and I've talked this with a lot of my guests, is information is one thing, but action is where it happens. And I appreciate your time and I appreciate your insights. Thank you so much for joining me.
Thank you.
Thank you for joining us on Moments of Experience. I hope today's conversation touched your heart and inspired you to reflect on the impactful moments in your own life. Remember, it's the seemingly small moments that often hold the most significant power to shape our lives and the lives of those around us. So keep your eyes open and do your best to be authentically present. If you enjoyed today's episode, please consider subscribing, leaving a review, or sharing it with someone who might benefit from our discussions. Until next time, I'm Geoffrey Smith, reminding you to cherish the moments that bring hope, connection, and purpose to your journey.